Hi, everyone. Good evening. I hope you all are staying safe and healthy in these difficult times. My name is Sacha. I'm the second year fellow at Mass General Fertility Center, and I'm going to talk tonight about ovulation induction, which is a very common fertility treatment. If you have questions, feel free to enter them into the chat field or the Q&A field, and I will do my best to answer them at the end. You might first be wondering, what is a fellow and how much training does she have? A fellow in reproductive endocrinology and infertility is a physician who has completed residency in obstetrics and gynecology and decided to pursue additional subspecialty training to diagnose and care for patients with infertility, among other things. The fellowship is 3 years and is divided between clinical training and research experience. And during the clinical training for infertility, the fellow learns about disorders contributing to male and female infertility and how to treat these issues. We are also trained in performing common procedures such as ultrasound, intrauterine insemination, egg retrievals, embryo transfers, and reproductive surgeries. And so it's a very exciting field to be a part of. Now I will move on to a brief overview of ovulation induction, tonight's topic. And I'm just going to share my screen here. All right, as many of you know, infertility affects 1 in 8 couples, and ovulatory dysfunction is a very common cause of infertility in women of all ages, and it affects about 25 to 30% of women with infertility. The goal of ovulation induction is to induce or stimulate the growth of a single follicle that will ovulate a mature egg in a woman who does not ovulate regularly. So how do you know if you ovulate regularly? Most women with periods every month are ovulatory, but if your cycles are longer than 35 days, you may not ovulate regularly. A common group of women who might require ovulation induction are those with PCOS, or polycystic ovarian syndrome, which is associated with irregular periods. Other groups of women who may have ovulatory dysfunction and require ovulation induction are those with, for example, hypothalamic amenorrhea, which is a condition in women who may have few or no periods in times of stress or excessive exercise, or perhaps an eating disorder. And another group of women who might have ovulatory dysfunction are those with premature ovarian failure or menopause before the age of 40. There are other hormonal imbalances as well that cause ovulatory dysfunction. And so this is a very common cause of trouble getting pregnant. So how do you know if you need ovulation induction? If you have irregular periods and are having trouble, getting pregnant over 6 to 12 months or so, then you can seek further evaluation with a fertility specialist to find out if that's contributing to your difficulty. So you will meet with a fertility specialist and undergo an initial fertility evaluation, as well as preconception counseling. And so this typically involves a very thorough history and exam to identify the cause of your infertility and to investigate your ovulatory dysfunction if that's an issue. This will also include prenatal screening as well as genetic screening. You will undergo laboratory testing, which will assess ovarian reserve, which is the capacity of the ovary to produce healthy eggs. You will also have additional testing that includes a uterine cavity evaluation and an evaluation of your fallopian tubes to ensure that the sperm can reach the eggs. So after all of this testing, you will discuss your treatment plan with your physician, and any other laboratory abnormalities or anything else that's discovered during the initial evaluation will be assessed and treated prior to undergoing fertility treatment, if that's what's indicated. Another aspect of preconception counseling is addressing, your overall general health and lifestyle. And so a few things that may be discussed are, for example, the importance of eating a healthy diet, maintaining a normal body weight, exercising on a regular basis, and avoiding activities like smoking or alcohol use during fertility treatment. Ovulation induction is typically the first step in treating otherwise healthy women who have ovulatory dysfunction. So if this is you, this might be a fertility treatment that is discussed in your visit. So what are the types of medications that are used to stimulate ovulation? There are a couple of different options, and your age, your ovarian reserve testing, and your specific diagnosis will determine what medications are recommended by your fertility specialist. The most common options include oral medications such as Clomid or Letrozole. Clomid, or clomiphene citrate, is a commonly used medication that actually acts in the brain to increase the hormone that stimulates follicles to grow, which is called follicular stimulating hormone. The typical starting dose is 50 milligrams nightly, and it's typically used for 5 nights at the beginning of the menstrual cycle. Clomid has been around for a long time. It is very well tolerated, although some women do experience side effects such as hot flashes. And the risks of Clomid primarily pertain to multiple pregnancy, so getting pregnant with more than one fetus, twin or triplet gestations. Twins, for example, occur in about 7 to 9% of women who use Clomid. And there is also a risk of what's called ovarian hyperstimulation syndrome. This is a lower risk than you would have, for example, when using injectable medications for an IVF cycle, but it is still a risk and essentially involves very elevated hormone levels that have an effect on multiple organ systems. Another oral medication that is commonly used is Letrozole, and that is a medication that acts through a different mechanism, but with the same essential consequence of increasing FSH secretion and thereby stimulating, hopefully, one follicle to grow. This is actually now the first-line medication in women with PCOS because recent studies have shown an improved live birth rate in women using Letrozole for this indication compared to Clomid. And this applies to women with PCOS of all BMIs, all weights. Letrozole, similarly to Clomid, is fairly well tolerated. There is no evidence of an increased risk of congenital anomalies or other negative impacts on pregnancy. And as far as why it might work better than Clomid in women with PCOS, some people have argued that it may allow for an improved hormonal milieu for implantation as one potential reason. Now, besides oral medications, there are also injectable medications or gonadotropins. And this is also a commonly used option in women who perhaps don't respond to oral medications. So a commonly used medication for ovulation induction, injectable medication, I should say, is FSH, follicular stimulating hormone, which I mentioned before. It is a medication that is injected daily to promote follicular growth. And so, as I said, in some women who do not ovulate with Clomid or Letrozole, this might be the next step that your fertility specialist discusses with you. As far as the dosing of this medication, there is quite a range, and that will be determined based on your age, your particular diagnosis, meaning what the cause of your ovulatory dysfunction is, and your ovarian reserve testing. So often patients, especially those with PCOS, will be started on a very low dose, and then that dose will be adjusted or increased as necessary through the cycle. This medication is, despite the fact that it unfortunately does involve an injection, is generally well tolerated. Some patients can experience abdominal bloating, fatigue, or headaches, but these side effects are typically pretty mild. Again, the risks of injectable medications, similarly to the oral medications that I discussed, do of course involve multiple pregnancy if multiple follicles are stimulated, and again, ovarian hyperstimulation syndrome if multiple follicles are stimulated, leading to very high hormone levels, high estrogen levels to be specific. And finally, another medication that is often used in ovulation induction cycles is called HCG, or human chorionic gonadotropin. And it is often used as a trigger medication in monitored cycles. So it essentially is given to simulate the natural LH surge and promote egg maturation and ovulation. So that is another medication that you might read about or hear about as a part of an ovulation induction cycle. All right, so now I want to review a typical treatment course for ovulation induction, just to give you a sense of what you might expect when undergoing this treatment. So at our center, ovulation induction cycles are monitored. What do I mean by that? So monitoring refers to transvaginal ultrasounds during the cycle. So at the beginning of your menstrual cycle, typically cycle day 3, the third day of bleeding, you will have a transvaginal ultrasound performed, which assesses the uterus and the ovaries and makes sure that everything looks normal, that there are no unanticipated abnormalities that need to be assessed further before starting medication. So when thinking about oral medications, I just have a diagram here that just gives an example of doing Clomid, for example, at the beginning of the cycle. We give the medication during the follicular phase, or the first half of the menstrual cycle, for 5 days. So, for example, cycle day 3 through 7. And then an ultrasound, if you are undergoing monitoring, is typically repeated. And at our cycle, we repeat the ultrasound on cycle day 12. And the purpose of this follow-up ultrasound is to assess your response, to see how many follicles have developed, and often you need another ultrasound, for example, if a follicle is not yet big enough, or the follicle may be very large, suggesting a mature egg, and you may be ready for the next step. So ultrasound monitoring does not necessarily improve pregnancy outcomes, but it does, like I said, help to assess a woman's response to medications and make dose adjustments as necessary. And in a monitored cycle where we're planning to do that HCG trigger that I mentioned for either timed intercourse or an insemination, the ultrasound monitoring allows us to determine the timing of that. All right, so with injectable medications, the overall idea of the cycle is similar, meaning you will have monitoring until the follicle or follicles is large enough to indicate that you are ready for trigger medication. But again, the injectable medications are taken daily. So this drawing just gives an example of that type of course. You might, after your baseline ultrasound on the 3rd day of your cycle, start your injectable medication, and you would take it nightly. And you're going to have more frequent monitoring during this type of a cycle to make sure that your response is appropriate. And so you'll have, at our center, for example, an ultrasound on cycle day 7 to assess your response. And you will also have blood work at each of these monitoring visits to check your estrogen level. And we check estrogen because we know that healthy growing follicles produce estrogen. And so that gives us an additional marker for how you are responding to the medication. And so the next step, as both of these diagrams indicated, is to think about timing the intervention for either timed intercourse or insemination, for example. And for that, we need to know the timing of ovulation, of course. And so ovulation timing can be determined using an LH predictor kit. So that is a common option in women using oral medications. Or if you are doing a monitored cycle, like I have described at our center, then when the follicles are large and are suggested that the eggs are mature, or will be mature, then the HCG trigger shot is given and ovulation is expected about 36 hours later. And so that is a benefit of doing the trigger shot. We can, time things very closely. And so we often recommend doing a trigger shot when we're planning an intrauterine insemination. So as I've referred to a couple of times now, the two options for the next step are either timed intercourse. So that is a common option in women who are using the oral medications, or intrauterine insemination, which is very helpful, particularly if there are other contributors to infertility, such as a male factor, for example. So I'll talk a little bit more about intrauterine insemination shortly. First, I just wanted to describe a couple of potential outcomes for these ovulation induction cycles. So as I mentioned at the beginning of this talk, our goal in women who do not ovulate is to make them ovulate. And so we want one follicle to develop. And so that would be our ideal response, for example, in a young woman with PCOS. There are a couple other potential outcomes. One would be a very high response. So someone takes Clomid for the first time, she's young, she has irregular periods, and you do your ultrasound on cycle day 12, and surprise, she has 4 beautiful large follicles. This would typically be an indication for, unfortunately, canceling the cycle and recommending abstinence. And the reason for this is to avoid, of course, a multiple pregnancy, for example, twins or triplets in a young woman, because those pregnancies are associated with much higher obstetric and neonatal risks. Another potential outcome would be a low response or no response. And so this may require, for example, changing to a different medication, switching, for example, from Clomid or letrozole to an injectable medication. Or it may be, if someone is already on an injectable medication and they're not responding, it could be suggestive of ovarian aging. It could be suggestive of something else going on. So we do learn a lot about the patient and her fertility diagnosis from the treatment cycle itself. All right, so just to talk a little bit more about intrauterine insemination, because it is very commonly performed with ovulation induction. Intrauterine insemination, you can see a little diagram here, is a procedure in which the semen sample is washed and the sperm are concentrated into a small volume of culture media. And then this solution of culture media and sperm are drawn into a syringe and into which is attached to a catheter, and that catheter is inserted through the cervix into the uterus, and the specimen is injected. And so this procedure is similar to a pap smear in many ways. It's performed with a speculum, like a typical GYN exam. And it is typically very well tolerated. Some women may have some cramping during the procedure or right afterwards, or may experience a little bit of spotting, for example. But typically, this is, like I said, a very well tolerated procedure. And here's another diagram from a different view of what's happening during an intrauterine insemination. You can see the sample being injected and all of those sperm being released into the tubes, into the uterus and then the tubes. And when this is performed right at the time of ovulation, of course, we are hoping that one of those sperm will meet the egg that has been released. Okay. Now, one other point about the intrauterine insemination, of course, it does require the male partner to provide a sample, and so that's typically done right before the intrauterine insemination procedure. And donor sperm, of course, can also be used in this procedure as well. So following an ovulation induction cycle with either timed intercourse or intrauterine insemination, the patient will take a pregnancy test about 2 weeks later if they haven't gotten their period to see whether the cycle was successful. So just a couple of words about the outcomes from ovulation induction. Pregnancy outcomes, as with any fertility treatment, really depend on a woman's age and her diagnosis. We do know from studies that for anovulatory women, meaning those who do not ovulate, so for example, those with PCOS, more than half, around 60 to 80%, do ovulate in response to Clomid. And of those who ovulate, about 30 to 40% end up conceiving, assuming there are no other fertility issues, which is sometimes a big assumption to make. And this certainly may take several cycles of trying. Again, the main risks of going through this treatment are the two that I mentioned, multiple pregnancy, so around a 10% risk of twins based on various studies, or having, because multiple follicles were stimulated, having ovarian hyperstimulation, which I described earlier. So if a woman does not respond to ovulation induction, if it's not successful for whatever reason, if they've gone through several cycles and it's, they haven't conceived, then you will likely discuss next steps with your fertility specialist, and that may involve proceeding to IVF or in vitro fertilization, which is a bit more invasive. And has a little bit more time intensive in terms of monitoring, etc. So that is a topic for another day. One other thing I wanted to mention is that the ovulation induction medications that I described, Clomid, letrozole, and injectable gonadotropins, can also be used in women with other diagnoses, so in women who ovulate but perhaps have unexplained infertility, to achieve what's called a mild ovarian hyperstimulation, or production of more than one follicle. So what I described in this talk was ovulation induction with the goal of obtaining one follicle, but in women, for example, who have unexplained infertility, there might be a goal of obtaining 2 or 3 follicles with mild hyperstimulation. And so that requires, again, very careful monitoring, and is typically combined with intrauterine insemination as well to increase the chances of getting pregnant. So at this point, I'm going to stop sharing my screen here to take a look and see if there are any questions from anyone. So one of the questions is, how do you know an egg is mature? That is a great question. So from studying follicular development, we know that typically, once a follicle reaches about 16 millimeters in diameter, that egg is likely to be mature at ovulation. And that is not always the case. Sometimes large follicles, for whatever reason, may have no egg inside or an immature egg inside. So that can certainly happen, particularly if there's some other component contributing to someone's infertility. Sometimes women with PCOS, for example, have more immature eggs. But this is often a consideration at IVF when you are recruiting lots and lots of follicles. When you are recruiting, one follicle and using timed intercourse or intrauterine insemination when that follicle is large, we of course hope that the egg inside is mature. Yeah, hopefully that answers that question. And any other questions? I'm seeing one in the Q&A. Can my mother's history of ovulation issues affect my ovulation ability? That is a great question, and it depends on what exactly the underlying cause of your mother's ovulation issues were. Things like polycystic ovarian syndrome, PCOS, or early ovarian aging, like early menopause, those things do certainly have a genetic component. And so in that sense, that would definitely be something to mention to a fertility specialist if you were to see someone in the office, so that they could take that history into account. Right. And I'll just wait for a couple minutes to make sure there are no other questions. All right. Well, thank you so much for joining. Hopefully I addressed those questions to your satisfaction, and hopefully this topic was interesting to you guys, and will help in the future with whatever potential fertility treatments you might be going through. So I will go ahead and close out the meeting if there are no other questions, and I hope you all have a great evening. Thanks so much.